So thanks for coming. Um, my name's Jessica. I'm a cognitive neuroscientist and professor of biomedical sciences at University of Rhode Island and the Butler Memory and Aging Program. And I'm going to talk today about retinal imaging in neurodegenerative diseases and how it can be used as an assessment tool. So, I'm going to go over a few things. Um, First, I'm going to talk about why we're actually targeting the retina um, for neurodegenerative disease markers, and then a little bit about some of the work my lab and my team has done in Alzheimer's disease. And then I'm going to talk about what's already been done in CADASIL and what is coming up. So we have three main ways that we look at biomarkers of neurodegenerative disease. Biomarkers are just biologic readouts that we can get from medical tests about disease status. So, for example, cholesterol is a biomarker of heart disease. If your cholesterol is high, you're at elevated risk of developing heart disease. And there are some biomarkers for neurodegenerative diseases. And we can use different techniques to look at those biomarkers. One that we use particularly in Alzheimer's disease, but other types of neurodegenerative disease as well, is called a lumbar puncture, where you obtain a sample of cerebrospinal fluid through the spinal canal. One is different types of brain scans, so MRI or PET scans. Both of these are with a lumbar puncture. You need a needle through the spinal canal. It's usually an 18 gauge. With MRI and PET, you need to go into a center with a scanner. Both of them are pretty high cost and not accessible to a lot of the population. Both of them need interpretation from a specialist. And so they're not really kind of feasible to use as biomarkers in primary care. Recently, there have been a lot of new biomarkers developed in blood for neurodegenerative disease. And again, this has been done a lot in Alzheimer's disease. Particularly different proteins, one called tau and one called amyloid. And they've been getting a lot more attention. They need further study in Alzheimer's disease. So why are we looking to the retina to find out information about neurodegenerative diseases in the brain? First of all, it's low cost. We can look at it using standard equipment in the eye doctor's office. It's not invasive, so you don't need anything to go into your eye. It's a camera that takes pictures. It's much more brain scans or lumbar punctures, and it can be interpreted easily by point of care doctors in optometry or ophthalmology. And I just want to go back to kind of basic anatomy to answer the question more thoroughly of why are we looking at the retina for neurodegenerative diseases in the brain. So the eye is actually an extension or a window into the brain. This is anatomy of the eye, and you can see the optic nerve here connects directly to the brain and to the eye, so they're joined. The eye and the brain develop from the same stem cells. They both are composed of the same types of cells. So we have um, brain cells, neurons. We have our axons with myelin on them, which transmit neural impulses. We have a blood retinal barrier, which keeps the things you don't want in your eye out and the things you do want in your eye in. And our brain also has a blood-brain barrier that does the same thing. And they both have a similar kind of vascular unit that perfuses the tissue. So basically, they're made of the cut of the same cloth. They have the same composition. And the idea is to use the eye as kind of an accessible piece of brain tissue that we can evaluate to look at what might be going on in the brain in various neurodegenerative conditions. As I said before, we get pictures of people's eyes all the time, optometry and ophthalmology. If you've been to an eye doctor appointment recently, I'm sure you got pictures of your eyes taken. It's very common to have images taken using different techniques in the eye doctor's office all over the world. And it's run commonly in a primary care setting, and older adults who very commonly have neurodegenerative disease also need to get their eyes checked more frequently just because of natural eye changes that come with age. So this is just a little bit of a more detailed picture of the anatomy of the retina. There's a lot going on here, but basically what you need to know is that it has a similar vascular composition. And this is a cross section of the retina from an image of the eye that's taken in an eye doctor's office. And what's really important here is that the anatomy is actually layered in a very precise way. And in each layer of the anatomy of the retina, there's a different type of cell or part of the nervous system. And we can get the thickness and volume of each of these individual layers pretty precisely with retinal imaging. And from there, based on what's in that layer, we might be able to infer what's going on in the brain in that person. So that's kind of the premise for looking at the retina to see what's going on in the brain in neurodegenerative disease. And my group's done a lot of work in Alzheimer's, particularly around detecting very, very early stages of Alzheimer's disease or Alzheimer's disease risk. But these techniques apply to all different neurodegenerative diseases. And there are two kind of main techniques that we use with our imaging. Again, that can be done on kind of standard equipment. One is called OCT, or optical coherence tomography. This here is a picture of an OCT image of the central retina, and this is another picture of the optic nerve and the rest of the retina. And these are what you would see when you're taking the picture with the camera. These are the images you would get. They refer to them as B scans, but you can see all the different layers of the retina there. And we can measure with automated software that's already in devices the thickness and volume of each of these layers. And we know a lot about their composition as well. And we look at different kind of areas. We separate the retina into different fields. That's not super important to know, but basically we have a standard way that we assess the thickness and volume of each of these layers in each of these fields. Another thing we look at is the blood vessels in the retina. And this is a picture from an OCTA, or optical coherence tomography angiography image. And basically, what you get when you take these images is a detailed picture of all of the blood vessels in the retina. And you can see in white here some bigger blood vessels, and then you can see the smaller blood vessels, complicated network of blood vessels that are nourishing the retina and bringing oxygenated blood in order to keep the retina healthy. This is actually my younger sister's eye, fun fact. And she was, I think, 19 when I took this, or 20. So this is an example of a very healthy 19 or 20-year-old. As you get older, the complexity of the vessels tends to become less complicated. You see less vessel density, so less space taken up by vessels and more blank space. And you see fewer vessels altogether. So we have this idea that we're going to look at what's happening in the brain through the retina. But we really, is this a true reflection of what's happening in the brain? So we need to look at whether it's feasible to do this, how accurate it is, and how could it be implemented. And there is kind of a known pathway for looking at biomarkers in any field. The first phase is discovery. So basically, we need to standardize the way we look at this and actually see if there's a difference between our symptomatic patients and healthy people around the same age. And my group is actually looking at the earliest stage of Alzheimer's disease in the retina. We're focused on people who don't have symptoms of Alzheimer's disease, already developing in brain the amyloid protein. And we know that people who have Alzheimer's, they start developing the amyloid protein probably 10, 15, even 20 years before they have their first symptom of Alzheimer's disease. So in other words, we have this silent period before someone's diagnosed where they're having these protein changes in their brain that are problematic and often result in Alzheimer's disease. And we want to be able to target that period for intervention, whether that be therapeutic intervention, behavioral intervention, whatever works. So we are looking at whether changes in the retina can identify this period, this preclinical Alzheimer's disease period, and identify Alzheimer's risk in older adults for them on for further testing and for treatment. So we've done some work on this, looking at changes in the retina and how they relate to other components of Alzheimer's disease. Memory and thinking skills, changes in gait, changes in the ability to function, looking at changes in blood protein, changes in sleep. And this was our first study called the Atlas of Retinal Imaging and Alzheimer's Study, or ARIAS. And basically the purpose was to look into the retina of these folks and see whether we could identify changes that were happening in people who were at high risk for developing Alzheimer's disease. So we had a group of folks who were what we define as high Alzheimer's. They had a first-degree family history of Alzheimer's disease, so a parent or sibling with the disease. They thought their memory and thinking skills weren't as good as they once were and may not be as good as other people their age. They carried a genetic risk for developing Alzheimer's disease, but they weren't having any substantive memory or thinking problems yet. And then folks who were at lower risk didn't have these genetic risk factors. So they didn't have history, first-degree family history. They didn't have complaints about their memory. They didn't have a genetic risk for Alzheimer's disease, but they still had the same no cognitive impairment. And we looked at these two groups and compared their retinas, their structural and vascular in their retina. And basically, the groups are well matched in terms of their age and educational background. There were more females in the high-risk group. And like I said before, they didn't have any noticeable memory or thinking problems. And we did find key changes in the retina between these high-risk and low-risk folks. We found changes in different layers of the retina. So we found the high-risk group had a thinner layer in three key areas. One was the ganglion cell layer, which actually contains synapses. Basically, it's where neurotransmitters move from one nerve cell to another. We had the inner nucleus, which is compiled of kind of amacrine, horizontal, and bipolar cells, so the actual cells that help you see. And then we had the outer plexiform layer, which is the communication between the rods and cones, which interpret what you see, and the bipolar cells, which transmit what you see to your brain. We also looked at the complexity of the retinal vasculature, and we didn't see differences in terms of how dense the vasculature was, the complexity, how kind of hard the vessels were, or their inability to be flexible. But what we did see is some functional differences. So we looked at these areas around the vessels that are black here. They're called capillary-free zones. So these areas are not receiving fresh blood. And the bigger they are, basically, the less healthy the retina is overall. And we found that these zones were bigger in the high-risk group than the low-risk group. Basically, meaning that if you're at higher risk for developing Alzheimer's disease, your blood vessels in the retina are not metabolizing oxygen as efficiently as people who are lower risk. So they're not processing the nutrients that are coming in. We also looked at how these changes related to blood proteins, and we found differences between the high risk and low risk groups in a couple of key layers. The nerve fiber layer is actually the axons that transmit our vision signal from the retina to the brain. And we found in the high risk group, we saw really no relationship between that and the level of tau in the blood. Whereas in the low risk group, we saw what you would expect to see, which is as the amount of tau in the blood goes down, the retina is thicker and healthier. True in the high risk group. So we found this for a couple other layers too. And basically, kind of the take home of this is that we were able to use these kind of retinal markers on top of kind of demographic information that you would use to predict Alzheimer's risk, things like age, education, and genetic predisposition. And when we added the thickness of these retinal layers, basically we were able to predict with about 90% accuracy who was at high risk and who was at low risk for Alzheimer's disease. So they really do add value to standard kind of demographic assessments that we would use in clinic. So right now, what we're doing, we did discovery work. We found key changes in key layers and key vascular changes, and now we're trying to validate it. So we are trying to look at whether it can be used to identify who will or will not develop Alzheimer's disease. And in order to do that, we're following a large group of people over time and comparing the changes in the retina to actual changes in the brain as measured by brain imaging, MRI, and PET scan, and changes in protein in the blood associated with Alzheimer's disease. And that is ongoing. And I want to switch gears here now and talk about how retinal imaging has been used in CADASIL in the past, and how we're planning on using it in the CADASIL consortium moving forward. So a lot of the work on retinal imaging has been done in Alzheimer's disease dementia. There hasn't been as much done in CADASIL. There's been some work in this area, but much less than Alzheimer's disease. The first work I want to show you is actually from a group at UCSF who is also part of the retinal imaging team on the CADASIL study. And it's Dr. Ahmed Abdelhak, and he used these kind of retinal pictures that we get to extract some very intricate metrics about the blood vessels in the eye. Basically, he was able to find the average thickness of the retinal vessels. So thicker vessels are indicative of, vascular pathology. And then they also looked at the vessel wall to the vessel lumen ratio, which is just the ratio of the thickness of the wall to the space inside the vessel for blood to flow. And they compared a group of healthy controls. They looked at people who had vascular cognitive impairment, so cognitive impairment due to vascular changes in the brain. And they looked at a group of CADASIL patients, and they found that on average, CADASIL patients had thicker vessel walls and a larger wall to lumen ratio, meaning that the vascular integrity of the retina was compromised in CADASIL, not only compared to healthy people, but also compared to other types of vascular dementias. And this is other work that has been done, and this is just an example of image of the retinal vasculature. And then you can see on this side, the red over here is just blood flow. So this is blood flow in the retina in real time. And this group looked at a group of CADASIL patients, 35 patients altogether, and a group of 35 healthy controls. And they basically found no difference in retinal metrics between the two groups. But what they did was split the CADASIL group into people who had had strokes and people who had not had strokes. And they found some interesting differences there. Basically, the group that had had strokes, they had less dense or complicated vessel structure in the retina, so less vessels overall, and less vessels nourishing the rest of the retina. And then they had thinner layers on the inner retina, which is focused on, again, cells that are responsible for transforming the images we see in everyday life to signals that go to our brain. Another study used a technique called adaptive optics. And basically, they were looking at something called vasoreactivity. So they flashed a light at the eye and they took a picture of the eye before the light flash and after, and they compared the diameter of blood vessels before and after. Um, and basically, what this told them was um, how well the eye was responding to stimuli. And they found this was in a small group of patients. It was 14 patients and 14 controls. They found in the CADASIL patients, overall, just their vasoreactivity was lower than the control group. A recent paper with 25 CADASIL patients and 40 controls found differences in retinal vasculature between the patient and control group. Again, looking at vessel density, the CADASIL group had less complex vasculature. They looked at something called perfusion density, which is the area of the eye or the retina that's perfused by different blood vessels. And they found that the CADASIL patients had less perfusion overall. So overall, the retinal vasculature is not functioning as well in CADASIL patients. They also looked at how this related to changes in cognition, memory, and thinking, and how it related to changes in the brain measured with MRIs. And what they found was that actually the integrity of the retinal vasculature was related to memory performance, cognitive performance overall, and how many white matter hyperintensities they found in the brain. So, CADASIL, we don't have a ton of data. I just went through 4 studies that have been done. That's pretty much all that we have. There have been some reviews that basically say, okay, so we have maybe a signal in the retina in CADASIL. We have signal in the retina in other neurodegenerative diseases. But what do we need to actually move this technique forward so that it can help people? And there's a few things. One is to standardize the way we collect the images and how we analyze them. One is to do this in a really big sample. So the more people that are in a scientific experiment, the more likely it is that your results are going to be based on true changes rather than kind of noise in your data. We also need to look at how each person changes over time in terms of their retina and their brain and see if the changes in the retina map onto changes in the brain over time. And then we also need to look at, all of these neurodegenerative, diseases are kind of continuums. So they, people start experiencing symptoms before they get diagnosed, usually. And they may have changes that are related to disease pathology way before they have symptoms. So we need to look at collecting data from folks who are preclinical or subclinical, all the way to people who are symptomatic in the disease process. So that is the purpose of kind of adding this retinal substudy to the CADASIL consortium. We have a large potential group of participants who are engaged in this research, and we're planning on looking at their retinal images, looking at these key metrics that we think relate to brain changes and analyzing how they may relate to changes in the brain as measured on MRI that reflect disease pathology, and also how they relate to genetics and how they relate to memory and thinking or cognition. Um, so this will address those barriers that I was talking about, the study that we're going to do. We have a big sample. We have longitudinal data collecting over time in people at different stage of disease progression. In my perfect world, once these biomarkers, if we see that they actually are workable, they do reflect changes in the brain, we would have a clinical workflow where we would have someone come in for a screening or an eye check at community optometry. This is not unprecedented. Already, optometry and ophthalmology screen for diabetic retinopathy, and some people may not know that they have diabetes, but they may have a red flag in their eye exam to refer them to their doctor for further testing. So the idea here is that we would kind of operationalize these tests into kind of an AI-assisted exam where there's very little room for, operator error or anything like that. We would have an output that is a risk stratification for neurodegenerative disease, and then we would refer patients for care based on their risk level. These are just people in my lab who have helped with our preclinical Alzheimer's work. I don't do anything alone. I rely heavily on others, and our lab doesn't work without our team. These are people I've collaborated with on the Alzheimer's work. And then this is the CADASIL collaborators. And I mostly want to just highlight not just the scientists behind this, but the research staff and the participants in the study who have been amazing and so willing to help. And these are the people who pay for the research. So I've talked a lot. I'd be happy to take some questions.
Thank you, Dr. Albert. It looks like we have a few questions in the Q&A box if you are able to take a look at those.
So the first question is there any possible correlation between retinal detachment and Alzheimer's disease? The answer to that is not that I know of. Detached retina happens to many people and is not due to any pathology associated with Alzheimer's disease. And I don't think it's any more common for people with Alzheimer's disease to have a detached retina. However, there are vision changes that are associated with Alzheimer's disease and other neurodegenerative diseases. The next question is, are there any risks associated with retinal imaging? Minimal. I mean, if you've had an eye doctor exam, you kind of know what the risks are associated with retinal imaging. Sometimes you get your eyes dilated before, and the drops can be a little irritating. You usually have to wait probably like 30 minutes after you get your eyes dilated to be able to see properly again, but that's temporary. Retinal imaging is non-contact, meaning there's nothing actually going into or touching your body. It's a camera. But there are flashes of light when they acquire the images. So it can be, a little bothersome if you don't like looking at flashes of light. And it can also be triggering for people who have epilepsy or are predisposed to seizure activity. Great question. Can the results be influenced by other factors? For example, if you have diabetes or other eye issues, cataracts, eyesight problems. That's a great question. Yes, they can be. So if you have complicated eye health, it can make it harder to acquire retinal images. So we can deal with cataracts, we can deal with eyesight problems. We can get good images if someone has diabetes. However, there is a problem with separating out changes to the eye that happen because of diabetes and changes to the eye that might happen because of other diseases. So that's a problem that still needs to be solved. In this research stage, we're really kind of excluding people with diabetes because we just want to look at pathology that's caused by a single disease. But I think it's going to be really important to look at people who have complicated eye health to see if this is still feasible in that population. Next question was, can retinal imaging results be used in combination with other assessments like MRI scans? Can it replace MRI scans? It cannot replace MRI scans. Not right now. Maybe someday in the future, distantly, but I doubt it. It would more be used to kind of refer someone who might be at high risk to a more complicated scan. It can be used in combination with MRI scans. Right now, it's not used clinically. Again, this research is kind of in like a discovery and validation phase, so it's not at the point where it's ready to use clinically. But I hope in the future that it can be used in combination with other assessments to assess risk. When was retinal imaging discovered as an analysis tool for Alzheimer's disease? What led to this, if you know? Probably the first studies of retinal changes in Alzheimer's disease were in the 1990s. It really started becoming more commonly looked at as like an assessment and biomarker tool in probably like 2010. And I don't know what led to it, honestly. It makes a lot of sense because they are, the eye, like I said, is kind of an extension of the brain tissue and has similar composition, but I'm not sure what led to it. Probably a combination of the anatomy, the physiology, and just having easy access. How do neurodegenerative diseases affect your vision? So different neurodegenerative diseases can affect your vision in different ways. So you can have changes in your ability to see contrast. So, see white writing on a black background. You can have changes in your ability to see peripherally or your peripheral vision. You can have changes in your ability to actually perceive objects. And then there are certain neurodegenerative diseases that are rarer, like posterior cortical atrophy, where the primary symptoms at the beginning are actually vision changes and vision loss. Is there a relationship between macular degeneration and CADASIL? That's a great question. I don't know the answer to it. There looks like there is a relationship between macular degeneration and Alzheimer's disease, but the work's still being done on that. And I don't know if there is between macular degeneration and CADASIL, but that would be actually a great question for our group to look at in this study. So thank you for asking it. Next one. Is there any possibility that biomarkers in tears or microscopic biopsies from eye tissue can be used to screen and diagnose neurological conditions? Wow, that's a great question. Um, I have read studies where they look at different proteins in tears to screen for neurological conditions. It hasn't gotten a ton of traction. I think it's hard to isolate the proteins in the tears. I think it's easier to look at blood or saliva. Um, I know that they can take tissue from the eye, but I don't think they do biopsies of the eye very often. So I don't think ethically that would work. Same reason we don't take tissue from the brain when someone's alive. Um, have retinal changes like you're measuring ever been used as a surrogate outcome in an intervention trial? Not yet. Um, they are, first, we need to kind of make sure that what we are capturing in the retina could is actually measuring what is happening in the brain. And then we can talk about using it as a surrogate outcome in an intervention trial. So the idea of that would be to reduce the time, invasiveness, and expense associated with clinical research. Can you test for or suspect CADASIL by looking at retinal imaging? For example, would spots on the retina mean anything given family history? And we don't know. We want to find out. So that's the purpose of doing this study with the consortium. I have a couple people um, asking, are participating in the consortium study and want to know if they're going to be asked to have retinal imaging. As of right now, I know that they are doing retinal imaging at 3 sites: Brown Butler, Wisconsin, and Emory. And I know that the consortium is also, the leadership has discussed flying participants to one of those sites in order to get retinal imaging done if that's something that they want. But I don't know if a decision has been finalized on that yet, so don't quote me on it. Are the vision changes associated with aura something that can be detected via retinal imaging? That's a great question. So migraine with aura often has associated visual changes. I do not know if we could capture that on retinal imaging, because what we're looking at is actually like the cellular composition of the retina. So I think that would be like a temporary change that's more functional than looking at the structure. So I do not think that's something that we could capture with this type of imaging. There are different kinds of imaging that you can do with kind of special equipment. The reason we use the equipment we use is that it's available in pretty much any eye doctor's office. And we don't want to get into using equipment that is super complicated and will, require people to buy a whole new piece of equipment and learn how to use it. But there are other types of equipment that capture kind of these functional changes that might be able to do what you are asking about, like being able to detect the functional changes associated with the aura. Do you have tips to maintain good eye health if you have vascular dementia? So I think in terms of good eye health, I think just maintaining a healthy heart does a lot for your retinal vasculature. If you have vascular dementia, there are lifestyle changes that you can make to help with blood circulation. There are medications you can take. For your eye health in general, there are drops and supplements that you could talk to your eye doctor about. If you have poor perfusion in the retina, but they would definitely tell you if they notice that at your eye exam. So unless they've raised something to you, I think you're probably doing everything you need to do. Has retinal imaging been helpful to analyze any other non-brain related diseases? Uh, so yes, it's been used in diabetes uh, quite frequently. Actually, it's kind of standard now at an eye doctor appointment for them to check for diabetic retinopathy. There are changes in the eye that happen when people get diabetes, and often that's like the first way people actually find out that they're at risk for or have diabetes. What is the difference between OCTA and OCT? I was in another study where they used these assessments. So the difference is OCT is looking at actually capturing the different layers of anatomy of the retina using a certain frequency of light. It captures a 3D image, and it takes advantage of kind of the cells under the retina called lipofuscin that reflect light. And basically it dings off there, and if there's something obscuring them, then it will appear dark. And in that way, you can get different layer measurements. OCTA is actually a different frequency of light and a different type of infrared imaging that is aimed at basically it presents a contrast, and the white in the OCTA image is vessels or blood, and then the black is areas without vessels or blood. So it's a certain frequency of light, infrared light, that captures the reflectance of blood and gives you information about the actual vessels and veins in the eye. They can both be done on the same device. You just have to kind of press a button and it will switch the light frequency, and they can both be done on kind of the standard device I was talking about in the eye doctor's office. I had retinal imaging done when I participated in a natural history of CADASIL study at the CDC. Did the different studies share info at all, or are they completely separate? Great questions. I think we're moving towards sharing more. I think we need to share. I think we all need to kind of adapt a universal protocol and share our images so that everyone can look at everything, and so that we have more data so that we can actually get these things validated faster. So right now, information is not shared. In the future, I think it should be. And this is from one of the consortium staff. None of the retinal imaging sites are up and going. They're working hard to get it started and hope to get the imaging started in the next couple of months. I should have said that. It's not happening right now. It's in a startup phase where kind of contracts are going out and things like that are happening, but it is coming. Next question. Can someone participate in the retinal study without having or wanting to know their diagnosis? For example, they have a family history of CADASIL but are not ready to be tested for it. We are not, the testing that we do or the images that we take would not be used for any diagnostic purpose in this study. So in other words, we will take the images and then we don't use them to make any inference about disease or diagnosis. what we would be doing is comparing them to MRI or cognitive changes, and then looking at that data on the back end, but we wouldn't use them to make a diagnosis. And we wouldn't be telling anyone anything about the images unless we found, something like macular degeneration or a cataract or something that they needed to get addressed. Can you get retinal imaging done at a doctor's office if you have dementia outside of research so you can find out your results? Not at this time. So, like I said, these are things we're studying right now, but they're not in clinical use at this point. Can retinal health with Alzheimer's dementia be genetically inherited? For example, having a family member who lost eyesight from the disease, is it more likely for someone in that family to experience the same? That I don't know. I know that, there are vision changes associated with Alzheimer's disease dementia. I don't know how heritable those are. I do know that Alzheimer's disease has a degree of like a genetic component, but that's not the only thing that determines whether or not someone gets Alzheimer's disease. I don't know whether vision changes associated with it are inherited. That's a great question, and I'm really sorry I don't have the answer. A message from Megan Caruso, our coordinator, saying, yes, people can participate without getting tested or finding out their diagnosis. So people can do the retinal imaging without finding out their diagnosis. Can other brain abnormalities be seen in retinal imaging, for example, a tumor? You can see eye abnormalities and you can see tumor in the eye from retinal imaging, but other than that, no. Yeah, I don't think brain abnormalities. I think, sorry, I thought you were asking about just tumors specifically. I guess the more complicated answer to that question is I don't know if we can see other brain abnormalities because it's like a kind of extension of CNS tissue. We should be able to, and actually, you can see abnormalities in the eye with multiple sclerosis, which is another white matter disease. So, yes, I think you can see some other brain abnormalities. Next question, last one. Does testing positive for CADASIL, Graves' disease, and glaucoma increase the chances of dementia? So I don't think that independently Graves' disease or glaucoma increase the chances of dementia. Those are two things you can see when you go to the eye doctor to look at your eye health. But I don't think they have independent contribution to risk for dementia. Having them in conjunction with CADASIL, I don't think increases your risk for dementia either. And then there was one other question in here about my contact information and sharing the presentation. So I know that Iman plans to, this is being recorded and she can send my contact information out if anyone wants to get in touch with me or has any more question.
Yeah, thank you, Dr. Alber, for that very informative presentation. We really appreciate it, and thank you everyone for your thoughtful questions. I will be sending a follow-up email with Dr. Alber's contact information, and the recording should be posted to our website in the coming week or so. If you have any further questions, feel free to email me, and yeah, thank you again for joining.
Thank you all for your time.
Bye.